global surgery and change. This is housed in the Harvard Medical School. It's an honor for me to be among distinguished guests and also to be the host for this inaugural webinar. Unfortunately, my partner, Andrea Winkler, is under the weather, and so please excuse her, but it really is a joint effort between Harvard and Technical University of Munich, where Andrea sits, and also Shabani. So I just want to acknowledge them. So, the Global Brain Health Partnership was started with three objectives. One is to really promote the idea of brain health equity. This is something that we're all after. We also want to learn from all the various stakeholders who see brain health as a mission for them, improvement of brain health. So learning is our second objective. And then thirdly is dissemination and then facilitation of knowledge exchange. And this is one of the way we're doing that is exactly this webinar. And this is the first webinar, and there'll be a series of them in the future. We have partners in India, Mexico, and Zambia. And we'll go and have webinars featuring some of these countries. So this is, I'm really delighted, and we do have a keynote speaker to sort of frame everything that we're doing today. And I have the honor of introducing Professor Vladimir Hachinsky. Hello, Professor. Professor Hachinsky is a legend, really. He's a distinguished neurologist, past president of the World Federation of Neurology. He's a neurologist by training and a distinguished university professor at Schulich School of Medicine and Dentistry and scientist at Roberts Research Institute at the Western University, London, Canada. I think most of us here know about the significant contributions that he's made to stroke and stroke care and understanding of stroke. But today he's going to give us a talk to sort of frame what brain health is. And at this point, I would like to turn over the mic to you, Professor Hachinsky.
Well, thank you very much for your kind words and also for inviting me. I'm excited. This is terrific. I mean, this is across the ocean and eventually globally. It is global, but I think we have to start somewhere. Well, the first thing is the world is aging. 3/4 of the countries in the world have more people getting old than being born. And this has consequences. The main one is that now neurological disorders have become the #1 causes of disability-adjusted life years, DALYs, which is a measure of early mortality and disability. And among these, more than half are due to stroke and dementia. Globally, it's 41% for stroke and 9% for dementia. In Germany and in the United States, it's a bit more even in that it's 56% in Germany and 52% in the United States, but the distribution between stroke and dementia are roughly the same. Now, one can ask what's happening with Germany, what's happening with the United States, for starters, in terms of what are the prospects of this divergence in aging and fertility rate. Well, in the United States, the life expectancy is 76, and the fertility rate is 1.7. In Germany, the life expectancy is 81, and the fertility rate is 1.3. So this is well below the replacement day figure of 2.1 average children per woman. So we're really facing a big challenge. So what is being done about it? Well, let's take dementia. We now have 3 drugs and a very important proof of principle study, the FINGER study, showing that intensive lifestyle changes can slow progression. The problem is that even if we had to stop all progression from cognitive impairment to dementia, next year there'd be more of them. There'd be more people with cognitive impairment. So I think the sensible thing to do is to begin implementing what the World Health Organization has advocated, which is, prevention begins at conception and brain health continues throughout the lifespan. That's a formidable task. However, a beginning has to be made. So first of all, well, what is brain health? There are many definitions. There are 2 things in common. Most of them are not understandable by regular persons. And secondly, none of them has a way of measuring the definition to see whether they're getting better or they're getting worse. Now, we're taking a very practical approach. And so our definition is when you're thinking, you're feeling, and you're connected with others is at best. Now, this is a lay way of saying, how is your cognition, how is your mental state, and how is your social interactions? And it's important to have the three together because the pandemic showed us that they interconnect and affect each other. If your brain was befogged by COVID, you sort of didn't perform well and didn't feel well. If you grieved, some of us did because we lost a close friend or family member, well, certainly didn't perform well and didn't feel like socializing. So it's also a more sensitive measure of the well-being overall because we tend to focus on cognition. But that's only part of what's important. And as cognition wanes, the emotional part and the social becoming more important. So we can maintain the wellness of someone overall, even when they're losing their cognitive capacity. So we've developed this very simple questionnaire based on those three items out of 7. And we began the process of validating this. We have co-opted 14 centers on 5 continents that already are doing standardized testing of cognition, mental status, social interaction. And we've asked them to apply our questionnaire and correlate it with these standard measures. Now, we just began, but we have an enthusiastic member of our team, Professor Giancarlo Logroscino in Bari, Italy, went ahead anyway without us coming to a consensus. And he studied 250 subjects, most of them with mild cognitive impairment. And he found significant correlation, statistically significant correlation between standardized measure of cognition, mental status, social interaction, depression, and interestingly, brain reserve. Now, if this is validated, we'll have an instrument that could be a screening test for cognitive impairment and for mental disorder and for social isolation. But we have another 13 centers to do it in different parts of the world in different settings. So we'll have to see how it holds up. Now, the advantage of a simple questionnaire is that the 3 key concepts can be conveyed in any language. So to that degree, it's really independent of language. It is also literally free. And we forget that in many parts of the world, people are illiterate, especially women who never get the chance to get an education. And then in terms of culture free, in the sense that it's not an absolute measure. It's a relative measure for the individual. And what measuring is change. So it can be applied in different societies, different countries, but the point is that it's not a comparison among countries. It's only good for that country, for those individuals, either individually or in aggregate. So then having a definition and having a way to evaluate it, what do we actually want to do? Well, what needs to be done, we've known for decades, I'm ashamed to say, but it hasn't been implemented because it's too difficult. So we're beginning by developing the basics in very simple terms that can be done. And so we have an A, B, C, D, S. A stands for activity, B stands for blood pressure control, C stands for connected with others, D is diet, and S is sleep. Now, I work with an expert group, expert in these areas, and I've said, give me the minimum that gives you the maximum. The idea is that if you get many people doing a few things, this amounts to much more than having a few things doing everything. So not few can do everything, but everyone can do something. So this is the power of population health, and that's the level at which we should be addressing it. For example, a decrease of 2 millimeters of mercury of systolic blood pressure is just barely meaningful for the individual. But at population level, it decreases the likelihood of stroke. And again, I emphasize that stroke and dementia and heart disease are interconnected. If you have a stroke, it doubles the chance of developing dementia. If you have a stroke, it gives you atrial fibrillation. If you have atrial fibrillation, it gives you a stroke. And it's also independently correlated with dementia. And the good thing is that the main risk factors, hypertension, the main protective factor, education, and I don't mean just schooling, I mean lifelong education, Are they common factors for all three? So if we do these things, then it applies to a large number of individuals. And to go back to an example of, what's a simple thing for the ABC? Well, it's move. You get the greatest benefit by moving. And so, for example, if you manage 3,000 steps a day, then you decrease the risk of early mortality. If you manage 3,800 steps, then you decrease the risk of dementia. If you do it someone else, you double the chances of continuing to do it. And if you do it in greenery, then you decrease anxiety, blood pressure, and heart rate. In fact, the Japanese proved this, and they have a term for it, Shurin-yoku, forest bathing. So having the instruments, well, we want to focus on the people. People don't like to change. I mean, let's face this, none of us wants to change. So we're focused on people who are undergoing change. So that's people about to retire or just retired, people, new employees, and then very importantly, expectant parents. Expectant parents will do for their children what they wouldn't do for themselves. And if you manage to teach them integral brain health early on, you set them up for life. But we're beginning with the easiest group. Well, not that it's going to be easy. Nothing is ever easy. But with the most prone to change, the people who are about to retire or have retired, they have more time, and their partners. Also, in Canada, people retire in their 60s. By that time, the risks of stroke, dementia, and heart disease go up quite quickly. And by that time, somebody in the family has had a stroke or has had dementia. So they're highly motivated to have a healthy retirement. And then the third part is that, well, the typical thing, we academics, I'm one of them, so if I criticize, I'm criticizing myself. We do a study, show that it works, and then hope somebody will implement it. Well, that seldom happens. So what we're doing is we're embedding the intervention in organizations that have as their priority prevention. Hospitals, which are overwhelmed with acute cases, and also family physicians. So we have a network of family physicians. In fact, it's Dr. Lickski, Lickski, of over 300 practices across Ontario, which are quite representative. Some of them are in low economic areas. It includes minorities in some areas. And what he has done is he has trained 30 technicians, educators, to deal directly with patients and teach them how not to need to go to a hospital if they have asthma, chronic obstructive lung disease, or heart disease, heart failure specifically. And he has shown that for each dollar the government gives him, he saves $3 in acute care. So he's quite willing for us to train some of his already trained and experienced people to begin applying the ABCD. And at the hospital, likewise, we have Dr. Andrew Appleton, who's an expert in lifestyle change. He already has a wellness clinic. So we are embedding. So the idea is that as soon as we show that it is successful, then that becomes part of what they do. And we skip the part about knowledge mobilization. And we guarantee that is ongoing. So what are the outcomes we're looking at? Well, we're going to do a control study, but it's not by individual, but by sites. We have enough of them to individuals, say, from the two hospitals have two campuses, one in the north, one in the south. So we really can't recruit people in one hospital to be the controls and the other one the intervention. And so the outcomes are, one, do more people take up one or more of the ABCDs? And that's an easy win because anything you do with individuals is better than doing nothing. Secondly, we expect that to be reflected on the Triad Index, which is a way of evaluating brain health. And very importantly, detecting and treating high blood pressure. This is the most powerful risk factor for stroke, dementia, and heart disease. And the lifetime risk of developing it is 82%. And only half of the people who have high blood pressure know that they have it or have it controlled. A fantastic opportunity because hypertension can be diagnosed and treated anywhere in the world with affordable medications apart from lifestyle changes. So the idea is that as soon as we show it among this specific group, we'll extend it to all employees, and essentially to our community. And we already have a number of willing communities that are willing to adopt at least part of it, a modification of it. What I'm really hoping for, that through the Global Brain Health Project, that many people become interested, and we're very happy to sort of develop in tandem, because, you know, what you apply in India may be different than we apply in London, Ontario. So we're learning to adapt the basic principles in different parts of the world so we can begin accelerating the progress towards implementing integral brain health.
Thank you, Professor Hachinsky. I always find your talks very enlightening. You know, what you mentioned, you know, one of the most important interventions is really lowering blood pressure.
Yep.
And that makes me think about the NCD community and how we should be reaching out and building bridges with them, right? Where we have the same same vision.
Yeah, well, sorry.
Please.
No, I agree, because you see, if you look at it, well, we're concentrating on the three things that I mentioned, but you know, the same risk factors apply to a certain degree to Parkinson's disease. They apply to bipolar disorders. They apply to retinal disease. They apply to, so I think that the one organ that can sort of, you know, without a healthy brain, not much else is worthwhile. So to say, look, and we also have to emphasize the positive and the here and now. You know, the idea that if you do all these things, that 20 years from now, you won't have a stroke. Well, that doesn't work. People can, frightening people doesn't help. If you can say, look, if you begin being a bit more active, eat a bit better, and interact more with people, you'll feel better, have more energy, you can do more. So you have the immediate reward with the long-term benefit.
Yes. So we welcome questions from the attendees. Please put your questions in the Q&A function on the bottom of your Zoom page. And we do want to spend a few minutes actually doing some sort of a Q&A with Professor Hachinsky. And if any of the current panelists have questions for Professor, please, this is a good time to do it. I also have some questions ready to go, but I wanted to give maybe Professor Golby. Alex, do you have any questions for Professor Hachinsky?
Well, I guess one question I have is reaching people who are currently not having their blood pressure treated seems like, even though it's relatively low-hanging fruit, it's still somewhat difficult because they've not been part of the medical system. And the sort of corollary to that is, how do you then establish that they are adherent to the treatment and that the treatment is effective, especially in areas that are more
Yeah. The first one is that, well, clearly one of the things that with the project that we're implementing, you know, we will be doing the blood pressures. And even in the control group, if it's beyond a certain level, we'll refer them because, you know, obviously we need to be treated that. I don't know, in Canada, for example, we have several organizations. One is a network of pharmacies that you can go and get a reliable one. I know that's true in the United States, at least in the state of Maine, where I had a vacation. And I think we have to think beyond doctors. And there are many more pharmacists everywhere. So one way is to actually empower pharmacists to treat and follow, and they're much better. And I'll give you a specific example. Ross Tsuyuki is the president of the Hypertension Society, and he did a study in Alberta, one of the provinces of Canada, where he took usual practice. It meant that the family doctor or a doctor would prescribe, the pharmacist will give the medication. And then the other one would be that the pharmacist could prescribe and follow them. It turns out that after 6 months in 24 different communities, this is the important point, they're reaching people who they ordinarily wouldn't have reached. There was a decrease in systolic blood pressure, but the people treated by the pharmacist was 6 millimeters of mercury larger. And in view of what I said about prevention of stroke and so on, this is huge. And probably the reason is that the pharmacists are very good at following up. And so they also get their medication from pharmacies. So they say, well, Dr. Mr. Smith, etc., or Madam Smith, please, we haven't heard from you. Are you okay? It's time for your medication, etc. And so you can establish networks, but we have to go beyond our usual comfort zone and begin recruiting other professionals, or even non-professionals, because really, probably if you can do the blood pressure right, and lay people can be taught that, they can also follow guidelines up to a point and self-treat. After all, diabetics don't confident themselves. So we have to change our mindset. It's one of the main points that I want to convey, that isn't simply implementing measures by the usual model. We have to change our mindset and be much more open and be willing to work with people who never thought of working before, including the subjects, because that's part of, I haven't got time to elaborate, but without involving them, no plan will work.
One thing I see in that we're learning from you, Professor Hachinsky, is that you think outside of the medical profession, because you need a lot more numbers of people who are involved in delivering care. And in your example, you gave the pharmacist. So I work in the surgery space, and we think the same. And you don't have to be a surgeon to be a surgical care provider. We think of midwifery, surgical technicians, OR technicians, community health workers, as part of the follow-up care. So we have to think of the entire ecosystem of healthcare delivery workforce rather than, professionals with lots of letters after their names. We are a part of that ecosystem, but not the ecosystem itself. There's a question here, just more of a comment about a neighborhood nursing program. And they set up shops in neighborhoods to provide free preventive care. This is an example of another way to deliver closer to the individual, right? Managing blood pressure, for example. Great, great. Any other questions from maybe the panelists that are here now? Please feel free to ask. I do have one question for you, which is, you're a global health expert, but you're also a country expert in Canada. The Canadian government comes to you and says, how should we manage, neurological conditions? What have you learned by working with the government in Canada? And then, what kind of advice do you have for other countries?
Well, I wish I could say that I have a close relationship and they always listen to me. I think the priorities of governments, well, I will be very unkind and I'll probably be paid the price. I think at least politicians or policymakers in Canada are more focused on the next election than the next generation. And therefore, it's very hard to persuade them to actually do the right thing. However, having said that, we're trying to organize a coalition. Well, first of all, as you probably know, the G7 met in Italy. And they now launched a brain health plan in Italy, and they organized a meeting prior to the meeting of the ministers of health in October of this year, a half a day where we're advocating integral brain health in all policies, and also encouraging to have the simple things, begin to fund and encourage new approaches at the population level, because there's plenty of academic efforts. And so the idea is that I've been invited to that, and it's organized by the European Academy of Neurology and by the Italian Society. But the interesting thing is that I've been giving the theme of implementation, and they've given the Ministry of Health of Italy the same topic. So he hasn't confirmed, but at least we're trying to persuade him. And the reason for having that is that the next meeting of the G7 is going to be in Canada, in Alberta. And so we're talking internationally. So not just Canadians going to the Canadian government, but the G7. So if we get them to adopt, and we're working on this. So it's not yet a project. We want to start by asking them to adopt integral brain health, in other words, cerebral, social, and mental, as a priority. Secondly, to establish a task force that will set the parameters of what it will require. It should be simple, it should be scalable, it should be applied in particular to the deprived areas. I mean, most of the stroke and dementia occur in the low-income groups and the minorities, and those we have to reach. And we cannot reach them from top down. We have to work with the people in the community. So that's number two. And then number three, we set the parameters, but we won't implement them. They already have government agencies. They already have health units. So we are guides on the side, not sages on stage. So that has a much better chance of being implemented. So I'm painting an aspiration. I don't want you to think we have this plan and the Canadian government is going to put it on the table and everybody is going to adopt it. But we did have a dry run in 2021. And that is that in 2021, the meeting was in Cornwall. And I happened, for each of the G7, they have a book, a background book of articles, typically by the heads of state, and then they invite experts of interest to that G7 meeting. So typically there are things about economics, the environment, and then the health. And I did one on brain health. And then there's a professor, John Curtin here, who leads research groups in the G7 and G20, and he monitors what they say. And he said, Vladimir, you have no idea, how many downloads and visits, I don't know what other things have been of brain health. Why don't you put together a coalition and put this on the agenda of the G20 meeting in Rome that year? So within short notice, over the summer, essentially, we got a big coalition with some big names. In the United States, Victor Zhao, as you know, is the president of the Medical Academy. In Canada, we even got to speak to the Prime Minister's office, but there was an election on, and I think that was not the best time to approach them. But the point was but the problem was COVID was on. COVID was in the agenda. And we had contacts who were told, you can try, but the agenda essentially set. It's really COVID. But nevertheless, with our efforts, we managed to have a mention about brain health in the communique. Now we thought, well, we'll try for next year. Well, the Ukrainian war started. And so we are now again trying to get the coalition together. And so it's not in the name of just Canadians, but it's, really internationally. So I hope I'm not saying more that we can deliver, but if we don't try, we won't. That's what they say in Canada, actually. If you don't shoot, you don't score. It's a hockey term. Like if you don't shoot at the net, you won't get a goal. We may miss, but we're trying.
I think we lost Key,
Oh dear.
unfortunately.
That's a glitch, is it?
We were going to transition to the panel. Let's see if Key comes back on. And in the meanwhile, maybe we can do some introductions. So the other panelists include Dr. Damija.
Alex, I can do it. You may have to put up with some intermittent coughing, but I'm happy to introduce the other panelists if that's okay. Then we give Key some time to come back on. So thank you.
We should also thank you very much to Professor Hachinsky for your presentation and for your discussion on these really important initiatives that have really meaningful chance to help people's brain health.
Yeah, no, Alex, exactly. I was just coming to it. But thanks again very much, Professor Hachinsky. It's really a pleasure to have you.
So thank you for giving me the opportunity.
No, you're welcome. Most welcome. So we're now going to transition to the panel discussion. And we have three very, very distinguished and very engaged colleagues. And I have the pleasure to introduce, first of all, Alex. I know Alex from my time in Harvard, where I'm a visiting professor. And Alex has always been extremely supportive of our Global Brain Health Partnership initiative. And I want to stress again the word partnership, because that's really something that we would like to implement good brain health where there's not a lot of brain health, but led by the country partners. And we will facilitate, promote brain health, as Ki has just mentioned, etc. And of course, creating a discourse, of course, transitioning into policy. However, also I would like to mention that the spark that actually ignited the Global Brain Health Partnership was the launch of the WHO IGAP, so the Intersectoral Global Action Plan on epilepsy and other neurological disorders. Just to wrap up, Alex, please tell me if Ki comes back on, because I don't see the screen just now. So I'm just
Hi,
going.
hi, Andrea.
You're
I'm back. I don't know what
Super.
happened. Yeah,
Super.
and my apologies. But
No worries.
please feel free to continue. I always enjoy listening to you, Andrea.
Well, maybe I just do quickly the intro and then I pass on to you, because I'll be very happy to then
Dankeschön. Yeah.
go quiet again. So Alex, it's always a pleasure. So you're distinguished neurosurgeon and the director of the clinical fMRI, functional magnetic resonance imagery service at the Brigham and Women's Hospital in Boston. And you're also professor of neurosurgery and radiology at Harvard Medical School. And you're holding the Haley Distinguished Chair in the Neuroscience Department at Brigham and Women's Hospital in Boston. You're also the principal investigator of the Golby Lab, a surgical brain mapping laboratory, and you have a very special clinical interest in brain surgery for patients with brain tumors and epilepsy, especially those lesions which are intimately associated with critical brain structure. I just can imagine what challenge that is. And Alex, you were also a recent Fulbright Global Scholar pursuing work, and now that is important for our partnership, to foster interdisciplinary collaboration between technical experts and clinicians in host countries like Rwanda and Morocco. I'm just handing back over to Ki, if you would like to start with Alex and then take it from there.
Yes, thank you. I just want to say one thing about Alex. I mean, not only she's a distinguished neurosurgery professor, but she's also a full-on global neurosurgery wonk. So we see two different areas, right? But they merge. We have the technical expertise, but we also look at the population, like that Professor Chinsky spoke about. How do we improve access to neurosurgical services and to those who don't have it at the moment? That's what drives us. So she's one of my colleagues in the program in global surgery and social change. Alex, so over to you about some opening comments.
Sure. Well, thank you so much for the introduction. One of the points that I want to start out with is that a sizable proportion of the deleterious effects on brain health are diseases that are treated surgically. And especially notable is that many of those affect young people and therefore have a very large effect on people's over the long term in terms of their quality of life, their ability to do activities of daily living, their ability to take care of their families, have gainful employment. So even though surgical disease is not nearly as common as neurologic disease, medical disease, it does have, I think, a very important impact because it disproportionately affects young people. And within those categories, we have trauma, which is a big problem. It's especially a big problem in the developing world due to road traffic accidents and less helmet use. And so being able to have systems in place to both prevent, but especially from the surgeon standpoint, to treat head injury, I think is one important area to build capacity. Another illness which disproportionately affects young people, in fact, is often a congenital condition, is hydrocephalus. And so that is also a lifelong condition. It's one that affects development, affects the ability to go to school, and it also requires lifelong care from skilled experts. So those two diseases and vascular diseases of the brain, and how those can be addressed either surgically or endovascularly, and then I'm kind of going from lowest hanging fruit to highest hanging fruit. Then we have functional disorders and epilepsy. So Andrea mentioned epilepsy and IGAP. Epilepsy is incredibly common, affecting up to 4% of the population. And there are about a third of patients with epilepsy who are medically refractory, and it has been established that surgery is much more effective than continuing failed medical treatment. In fact, of the things that we do as neurosurgeons, it's one of the few that's really been shown by multiple randomized controlled studies. And movement disorders also can be addressed with surgical treatments and tools. What makes these more difficult, epilepsy and movement disorders, is that they require a tremendous amount of multidisciplinary team approach, and also technology. So there are some areas in which there's relatively lower hanging fruit, such as classic temporal lobectomy, that can be taught and applied, but there's also a lot of patients who need a much more complicated approach with not only neurosurgery, but neurology, neuropsychology, sophisticated imaging techniques, electrophysiology, et cetera. So I think those illnesses are things for us to really think about. Again, they have a huge impact in people's quality of life. And then you mentioned that I've worked in the intersection between technology and clinicians, and so I want to kind of put a plug in for collaboration with our colleagues who are biomedical engineers, computer scientists, other technical experts, especially locally, because they can help to address the problems that local clinicians are treating or finding, or are making their treatments, are limiting their treatment options. And there really is no substitute for kind of a local understanding of what the challenges are, and then pairing with people who are technical innovators to solve those problems. So, for example, we know that after surgery, monitoring patients closely is critically important. And that's a combination of training of staff in, for example, an ICU to assess the neurologic exam, but there may also be technical or technological tools that can help alert folks to deterioration that would indicate a problem. So I'll kind of finish there for now.
Thanks, Alex. You know, you touched on the technology aspects of it. I don't know if you saw recently, there was a really nice article. I think it was in one of the mainstream journals here in the US, either Time magazine or the New York Times or Wall Street Journal. A journalist had brain tumor taken out, and he looked at focused ultrasound, right, as a sort of potential future, which is non-invasive, right? It's so I use it as an example of things that are applicable maybe in the LMIC setting, or other technologies that you think could potentially revolutionize the delivery of neurological care, neurosurgical care in these areas where they don't have any. I mean, let's be provocative.
Yeah.
Is telesurgery a reality, or is it going to be reality?
I think there's no technical obstacle to telesurgery, right? I think the biggest question really is where is it best applied? How is it best applied? On some level, doing telesurgery involves doubling the number of surgeons involved with the surgery, potentially. So it may not be the most efficient way to deliver care. As regards focused ultrasound, which is a technique that is really coming to the fore, both for creating intentional lesions for the treatment of movement disorders and perhaps psychiatric disorders as well, and also separately using a slight variation of the technique, opening the blood-brain barrier, which could literally open the door to a large number of therapeutics that have not successfully reached the brain, therefore potentially allowing us to revisit a lot of drugs that have been discarded as potential treatments for brain tumors and for other diseases as well. Right now, that technology is incredibly resource intensive in terms of requiring MR scanning, the device itself, which is millions of dollars, and also a tremendous amount of expertise. But we've all seen things go from being rare and very expensive to being totally ubiquitous. And, in my lifetime, when I was a teenager doing rotation in a pediatric ICU, they got their first ever pulse ox, and they moved it from patient to patient to get those measurements, which were invaluable to them. They had never had anything like this before, and now we all have pulse ox potentially at home for $10. So technologies do become simpler and more ubiquitous, but we need to make that a priority, because technologies are also made by companies, and companies like to make money. And so the sort of equation of high cost, low volume to a certain market versus lower cost, much higher volume, if we can reach a much larger market of essentially the whole world, is something that I think we have to advocate for at a high level in terms of policy changes that sort of encourage that type of later stage translation. So we often talk about translation to the clinics, but there's a kind of a later stage of translation to make things simpler and more accessible.
Excellent answer. I'm just thinking out loud. This is the inaugural webinar for the Global Brain Health Partnership, and we're planning some regional webinars. But I think perhaps we should intersperse that with some thematic webinars, like industry, technology, innovation, in terms of expanding brain health care delivery. Now, you're also a professor of radiology in addition to neurosurgery. What do you have in terms of low-cost imaging, right? I'm hearing stories about MRIs that are light enough where you can lift it up and move it. Is that a reality? And what is that? What are the implications?
Yeah. So there are a number of technologies that are being developed that are lower cost. And the low-cost MRI is potentially a game-changing innovation. So the challenges to citing an MRI cannot really be overestimated. We in the US take it for granted. At my hospital alone, we have close to 20 MRI scanners, which is embarrassing in a world where there are countries that have only one or two for the whole country. And why is it so difficult? Well, the capital costs are significant, but so is the underlying infrastructure necessary to site an MRI scanner and to keep one running. So the technical expertise needed to do routine service and then service when the device breaks down is really significant. And then finally, conventional MRI scanners require cryogens, and that takes the form of liquid helium, which is a scarce resource. There is a finite amount of helium on this planet, and it's getting more and more difficult to get it and more expensive. So there's been a big push towards cryogen-free MR, and there's a number of groups working on this, both academic and commercial. And I think that it is potentially a big game changer. One example is in the treatment of stroke. So diffusion MRI allowed us to see strokes well before we could see them previously on CT. And that really opened the door to the endovascular treatments that people are receiving, which are changing the outcome for stroke. So a large percentage of patients, if they can get to the hospital in time and have this type of imaging that confirms that there's a stroke, will be candidates for endovascular treatment or just TPA. And that's relatively relatively easy to see big, large strokes, even on a scan that is very low field strength. Detecting more subtle things like changes in the hippocampus in Alzheimer's or the epilepsy, lesional epilepsy, that we're quite a long ways away from that with low field scanners. But again, I remember the very earliest MR scans, which took nearly 2 hours to acquire one brain scan and were relatively low resolution. And now we can do a whole brain in just under 20 minutes at much higher resolution. So technology marches forward, and we just need to kind of capitalize on that.
Well, Alex, we can go on and on. I love, and you talk about endovascular treatment. That's another technique that's amenable for telesurgery, right? Remote, the control of the robotic arms to manipulate catheters. Okay, so we're gonna go on to Professor Owolabi next. But before I introduce him, I want to make sure that we are trying to get Professor Jamija up on the panel list somehow. We're still looking for him. But I want to introduce really a distinguished neurologist. His reputation is incredible. Professor Mayowa Owolabi is in Nigeria. He's the professor of neurology and director of the Center for Genomic and Precision Medicine at the University of Ibadan, Nigeria. He's a global leader in brain health and global health, especially for NCDs. He's among the global top 2% of scientists and winner of the 2021 World Stroke Organization Global Award for outstanding clinical stroke research. He also is the African Regional Director of the World Hypertension League. He's the lead co-chair of the Lancet Commission on Stroke, and he chairs the Lancet Commission on Neurorehabilitation and is a member rapporteur of the WHO Technical Action Group on NCDs. Professor Owolabi, did I leave anything out?
No, I think that's just fine. Thank you so much for a very generous introduction. If you would permit me to just share my screen. I just have a few slides to show. 1 second. Yeah. Okay. Okay, I think this must be it. Thank you very much. Yeah, this. Okay, let me start from the first slide. Coming, sorry. Okay. Let me just scroll it to start from the beginning. Sorry. Okay. Thank you very much for this opportunity. Yeah, so I'll be talking about global brain health, my perspective about global brain health. A lot of what I'm going to say have been said by the father, so to speak, of brain health, and that's Vladimir Chinsky, and I'm happy to be with him on this panel. So, of course, we know that neurological conditions are the leading cause of disability, and they are also extremely expensive. Stroke alone, from the Lancet Commission work that we did, cost close to $1 trillion dollars per annum, and that's even projected to continue to increase. Dementia alone, costs about $1.3 trillion, and that's, I'm sure, is also increasing. The top conditions that are responsible for the disability related to neurological disorders, about 37 of them. Topmost, of course, is stroke, neonatal encephalopathy, migraine, dementia, diabetic neuropathy, meningitis, epilepsy, preterm birth, autism disorders, and of course, traumatic brain injuries, Parkinson's disease. And the pattern or spectrum varies across the life course, initially starting with neonatal encephalopathy, but then meningitis, and then migraine, then stroke, then dementia. So, and that's why we need solutions across the life course. And so, a lot is going on about AI, but I think what is more important really for the human race is a neurologic revolution, whereby we pay a lot of attention to brain health and brain power, because brain health is actually critical to everything that we do. So, and that's why the neurology revolution is very important, which you are also trying to, through this panel, of course, through your activities or the activities of this panel, we'll be able to push this agenda. So brain health is a complete functioning of the brain across the life course. And that is essential to support full physical, mental, social, and spiritual well-being and quality of life of an individual towards attaining and maintaining the epitome of a meaningful, impactful, purposeful, and productive life. So the concept of brain reserve has been mentioned uh, by Vladimir, protection, promotion, and of course, you mentioned. And we also, between myself and him, also proposing supermentia, which is really to ensure that we are able to improve brain functioning or optimize brain functioning, not just improving how computers work and then we have AI, but how do we optimize brain functioning? Is it going to be just through the brain, or is it going to be brain-computer interfaces, and so on and so forth? So, well, what is really helping the neurology revolution, or what has sparked the neurology revolution, is WHO ICAP, which is what we're talking about today, and it's about raising policy prioritization of brain health, providing effective, timely, responsive diagnosis treatment, implementing strategies for promotion and prevention, and of course, fostering research and innovation to strengthen information systems. And of course, really, it has to be population level interventions and public health. Since 1 in every 3 people have a lifetime chance of having a neurological condition. So we're looking at a world where brain health is valued, promoted, neurological disorders are prevented, diagnosed, treated, premature mortality, morbidity avoided, stigma is reduced, and we will be working through the primary healthcare centers, and of course, universal health coverage, intersectoral, multisectoral action, gender equity, human rights. Those are all very, very important. So it starts with prioritization, putting the necessary priority on the brain, which is the most prized, I would say, human belonging. I mean, the best of us is actually the brain, and that's why it's on top of the rest of the body, and and health is wealth, and you can't even talk about health without brain health. So diagnosis, treatment, promotion, research, innovation, and so on and so forth. So we came up with this, which actually summarizes our vision for global synergistic actions to improve brain health for human development. That's published in Nature. And brain health is central to all the SDGs. because without brain health, there is no health. And without health, there is actually all the other ones really will not work. And brain health is pivotal to physical and mental health, social health, and of course also to planetary health and spiritual well-being. But when you're talking about how do we really realize these objectives, we came up with this idea of the brain quadrangle, surveillance being very important and research, prevention being very important, acute care, and of course rehabilitation. So, and there are a lot of barriers to implementing or achieving a world where everybody has the best brain health and is able to function optimally at their very best. So systems at the system level, there are a lot of provider level, at the patient and community level. Patient and community level, of course, is about awareness, about what to do to protect the brain, some of which have been mentioned by Vladimir Achinsky. Provider level, the main problem that we have is actually the inadequate number of trained personnel. And that's a major challenge across the globe, but is most biting in low and middle income countries. In Africa, there are so many countries without even a single neurologist, and a lot of countries with a population of 50 million or above with only 10 neurologists or even fewer. And that's not to talk about other neurological professionals like speech therapists, psychotherapists, and so on and so forth. So it's a major issue. So our vision of protecting and promoting brain health is not just about adding years to life, but life to years and meaning to life, self-realization, self-actualization. And brain health, we are in a global economy that is driven by brain power. So really we talk about brain economy, which really depends on brain skills and our cognitive power. And that's why brain health is really so important, because we're in a knowledge economy. This is from an article jointly written with Vladimir. The centrality of brain health to everything that we do. A lot of factors influence brain health, and we need to, if we are going to really tackle brain health, we must address social, political, biomedical factors, psychological factors, and so on and so forth, and must have a life course approach. And so this is about the brain quadrangle, which is extremely important. Surveillance, research, innovation is important so we can really know the burden of disease and the impact of the intervention at population level. Prevention is extremely important, and this applies to everybody because everybody really is at a lifetime risk. So we need to identify modifiable risk factors and tackle them. And I will still talk about some of them like hypertension, dyslipidemia, obesity. Then treatment and acute care. We've mentioned a few of those, particularly using stroke as an example today, about thrombectomy, about MRI that is actually not using helium and all of that, portable MRI and so on and so forth, telesurgery, telemedicine, and so on and so forth, rehabilitation, chronic care, and palliative care. All of these are important. And of course, at the very center of this is prioritization and strengthening of the health system. That's the only way this can happen. And it must be an holistic approach that is looking at capability, opportunity, motivation, not just stopping at guidelines, which is what most of us do as clinicians, but looking at the implementation structure that is really very holistic, fiscal measures, regulations, legislation. Some of this legislation may help improve lifestyle by targeting social and commercial determinants of health, including brain health. So we illustrated these in the Lancet Commission on Stroke with these 4 pillars also, the 4 pillars of the brain quadrangle, and this was launched last year with a lot of press coverage, including CNN, and disseminated across over 200 news channels. And we have about 322 commissioners, 84 countries that did this work over a space of almost 6-7 years. And we came up with what can actually help to reduce the burden of stroke across the globe, across these pillars. And we know stroke is a very dominant cause of neurological disability. And if we really deal with stroke and dementia, a lot of the burden of neurological conditions that are affecting brain health would have been decimated. So we projected the burden up to 2050 and also the cost. And we actually have a publication also on primary prevention. This is on neurorehabilitation, the multi-sectoral or the multidisciplinary nature of neurorehabilitation and why you need a lot of different disciplines to really be able to attend to the needs of the patient. And different paradigms that are important for neurorehabilitation, neuroplasticity, biophysical, adaptive, psychospiritual model, all of these are evolving. of course, helping people to live a meaningful life, including achieving self-transcendence, not just dealing with physiological needs or safety needs, but actually going up the Maslow's triangle or pyramid. Spirituality is becoming important and something we need to pay attention to. Energy therapy, but these are areas that I imagine that requires a lot of understanding, definition, and objective means of assessing these and using these as means of intervention. So really, neurology revolution is evolving on the wings of the psycho-spiritual aspect as well as biophysical aspect, including innovative things such as artificial intelligence, human brain projects, human affectome, human connectome, new technologies, and so on and so forth, neurorobotics, bionic eye, a lot of things are going on, and brain spine injury that can almost make what looks just like a dream, almost like science fiction, is becoming reality. Neuromusicology, neurolinguistics, all of these are also going on. The role of the humanities in neurorehabilitation, Ikigai, and so we need to, we can engage them at the World Economic Forum, at the G7, G20, WHO level, but also implementation partners, different organizations and NGOs that are involved, commissioners or advocates or ambassadors in different countries. One neurologist is trying to do this, but then we also must reach to the general population through advocacy, through the social media, payers, funders, patients, caregivers, their family, policymakers. This is really everybody's business. Everybody that has a brain, really, is everybody's business. So a few illustrations from Africa. I know that's supposed to come later, but it's like I have another meeting, so I just want to quickly mention this. So in Africa, we try to domesticate the agenda of the WHO gap in Africa, covering the 47 countries. So we prioritized 5 cardinal conditions that are really common: stroke, dementia, epilepsy, Parkinson's disease, headache. We did a situational analysis, and then we came up with key recommendations, like research and academic institutions to create and transfer knowledge and innovations, pragmatic solutions for each of these conditions. NGOs to help with education, like social support organizations, for instance, World Patient Alliance. The private sector to come up with cutting-edge products like point-of-care devices, that may be useful for screening and, of course, dealing with the conditions that predispose to stroke, including hypertension, dyslipidemia, diabetes. Policymakers to prioritize and allocate resources, and we're engaging policy. In fact, the report is supposed to be launched at a meeting to be hosted by the WHO Accra region. That's yet to happen. Hopefully, that will happen this year. Laws on disability and to protect people living with disabilities. So there are key challenges in Africa: fragmented care system, prioritization issue, also limited number of the multidisciplinary workforce. Essential medicines is something that is limited access to for conditions like Parkinson's, like even seizure disorder. Governance and legislative gaps, all of these are very important. So, and we have solutions, including intersectoral interventions across all of this. And I will illustrate with what we've done with stroke in Africa. This is probably in Lancet. We have identified the key contributors to stroke in Africa, and it's not infections. I mean, it's still the hypertension, the lipidemia, diabetes, and there was a surprising and pleasant surprise, finding of the dose-response relationship, protective relationship of consumption of green leafy vegetable against stroke, which we also demonstrated against hypertension. And we came up with a stroke educational video and a riskometer, Afrocentric riskometer, based on our findings, which has helped with blood pressure control and reducing the risk of stroke also. And this is something I must mention, the success story of Norway. Brain and vascular health. By having a brain health policy in Norway, it reduced not only ischemic heart disease, but stroke by more than 30% over decades. So this is something that should be adopted across different countries. So, and when you are preventing stroke, you are preventing dementia, you are preventing ischemic heart disease and other neurodegenerative conditions. And of course, we always focus on atherosclerosis, hypertension, but we should also take a step backwards and look at political, legal, anthropological, commercial determinants, environmental factors, look at primordial prevention, primary prevention, secondary prevention. And so we're championing this in Africa with the Achieve ecosystem to accelerate the prevention, so the control of hypertension on the continent. And the African Stroke Organization, we also established this. And the keynote speaker at the establishment of the African Stroke Organization 3-4 years ago was actually Vladimir Achinsky. And we do have conferences which we've hosted every year. And there's going to be one in Zambia this year, which is hybrid. So we came up with this, which involved WHO, involved World Hypertension League, involved International Society for Hypertension, it involved No Patient Alliance and Ministries of Health. In fact, the Minister of Health in Ghana was in attendance in person throughout the course of that program. And we came up with a communique which he also signed and a publication also on that. So, and the 80-80-80 target to improve the detection control of hypertension on the continent, because only 7% of those who are hypertensive are controlled at the moment, and that's why the risk of stroke is very high and very alarming. And so there was an editorial on this as well, and a lot of other things we're doing with the World Federation for Neurorehabilitation, training programs to build the workforce, like the Talents Program and the GRASP program, and of course, the Lancet Commission on Neurorehabilitation. Thank you so very much.
Thank you, Professor Owolabi. Can you stop sharing for a second? Great.
Yes.
So I've been reminded by our team in the background that we would love to get a screenshot of all the panelists in one. So if you're panelists, can you turn on your camera? I don't know if Professor Hachinsky is still able to hear us. Yeah, if you can turn on your camera, that'd be great. Wow, there he is. Okay. So great. Ramya, go ahead. Yeah.
Happy group.
Yes, yes. Hopefully it looks great. Okay. Oh, Professor Owolabi, thank you for that talk. I mean, there's so much more behind that, obviously. I have to congratulate you on really what I would consider masterful advocacy on top of your clinical and research expertise. Your phrasing, right? The quadrangle, the life, years and years with life. I think these are beautiful messaging. So congratulations. I am learning from you. And in terms of advocacy, I'm going to come to Professor Rajendra Damija. He's at New York right now at the UN General Assembly for this kind of reason, right? We have to be at the table to raise the issue here. So I just want to say that Professor Damija is once again, distinguished neurologist, professor of neurology, and director at the Institute of Human Behavior and Allied Sciences, New Delhi, India. He brings about 30 years of extensive experience and exceptional accomplishments in neurology and in public health. He's led pioneering research in neurology, especially in stroke and movement disorders, and has been appointed the chair, and this is quite important, more recently in India, the National Task Force on Brain Health by the Government of India. Congratulations. And he's also the Lancet Commissioner for his work in neurorehabilitation. So, Professor Damija, thank you for joining. I know you're quite busy this week, but I'm so glad that you can participate. This is the first under the inaugural webinar. We hope to have you join in the future ones. But can I turn the mic over to you for some comments first?
Good morning from New York, and good afternoon and good evening wherever you are. Thank you very much, Professor Sarvani, Dr. Key, Dr. Andrea, Professor Hachinsky, and Professor Mayowa for starting this very important webinar on the partnership, which is a historic moment for the brain health in this era. We are lucky to witness this, and we are here to support the efforts of at the global level from different stakeholders. This is something very historic, and I'm really privileged and honored to be part of this. Although I'm in the United Nations for the Brain Health Summit, the Science Summit on the Brain Days, and I have come out of the meeting to attend this important webinar. And I'm glad that I could make it, although there were some technical hitches in last half an hour, but finally we managed to log in. So coming to importance of brain health at the lower and middle income countries where I represent, and my work has been there for the last 30 years. So in India, coming to India, I was asked to give some insights to the brain health achievements in last 30 years in the context of public health and the promotive preventive brain health. So we have come a long way, but as you know, India is a very heterogeneous country with 1.5 billion people and with a huge urban-rural divide. So there is one neurologist per 1 million population. So about 3,500 neurologists at the moment working in the country, and 80% of these neurologists are in the urban metropolitan areas. So you can imagine that number one, the one neurologist per 1 million population, and that too also concentrated in the urban areas and having poor accessibility, availability, and acceptability of neurologists, and of course the whole ecosystem of having different streams of medical practice, complementary medical practice, alternative medical practice, including Ayurveda, Unani, and other streams of medical practice apart from the modern medical practice, which is very widely practiced in India. So these are something which these are something which we need to face every day, and for our patients, which we have to deal with day in and day out. So that's number one. Where we have progressed in last few decades, the telemedicine and the teleneurology has come up in a big way, thanks to COVID, and now it's legalized in India as per the regulators that you can practice teleneurology and as well as telerehabilitation. So there is a lot of research and a lot of evidence now coming up. For example, telerehabilitation in Parkinson disease or telerehabilitation in stroke patient. So rehabilitation as such, a continuum of neurological care is a very, very primitive. So whether it is traumatic brain injury or spinal cord injury or stroke or neurodegenerative conditions like dementia or Parkinson. So there's not much of structured neurorehabilitation in the country. So the community-based rehabilitation or home-based rehabilitation is the mainstay of rehab, serving the larger population. Very, very few structured neuro rehab centers, or in fact, rehab centers in the country. So that is something we need to work, and the government has taken cognizance of this. Regarding major neurological disorders, we have had a very big GBD study focused on India, where we have now the neurological burden across each and every state in India. And we have the 10 top neurological disorders, which are more prevalent in some states and less prevalent in other states. So that gives us a burden of disease in the country to plan future strategies and to plan public health policies in the brain health. So that is number one. That publication came up in Lancet last year, where we have state-wise burden of neurological disorders in India, more or less similar to the other developing countries, but there are three key points in this burden of disease study. One is that the non-communicable neurological disorders. So non-communicable neurological disorders have come down in last 1 decade. So for an encephalitis, meningoencephalitis, tetanus, rabies, all these have come down. But communicable, sorry, that way, other way, the communicable neurological disorders have come down. The non-communicable disorders have gone up. So non-communicable like vascular neurology, degenerative neurology, they have gone up. And communicable neurological disorders, which are infections-related neurological disorders, they have come down. And the injury-related neurological disorders like traumatic brain injury and other spinal cord injury, they have also gone up. So the key point is that communicable neurological disorders going down, non-communicable strokes, vascular degenerative neurology going up, and injury-related neurological disorders also going up. So these three are very, very important information to plan our public health policies at the level of Government of India. The other point is since we are talking about brain capital, brain economy. So the Government of India at the moment is spending only 1.1% of the GDP on the health. Leave apart the mental health, brain health. The total expenditure of government in the public sector or public health is 1.1%, where we aim to increase into 2.5% by 2025 and 4% by 2030. I don't know whether we will be able to achieve it or not. Compare it with the Western countries where we have 11%, 12%, 16%, 17% in many countries in the Europe and Australia and US and Canada. So 1.1% of it fifth largest economy in the world. That is what we claim to be fifth largest, and we aim to be third largest after US and China by the 2047. So obviously, the huge economy, the GDP is huge, but expenditure on health is meager. So where we have been advocating for the government to increase this money spent on the public health system, on the whole, there is 4 to 5% of the GDP being spent. That includes the private sector and the public sector. So major chunk of the money being spent is on the private sector. From the government point of view, is only 1.1%. So that's another peculiar thing coming from the Indian policy makers. So that is something very important. Third point which I make to highlight here is that the being the heterogeneous nature of the population. The population is we claim to be a young nation with 35% of the people living less than 35 years of age. But at the same time, we also have a glaring burden of aging population. So our aging population is around 10% now, but in next 20 years it's going to double. So it is going to be 20%. Imagine 1.5 billion people, of which 20% or every fifth individual is more than 60% of the age or 60 years of the age. So obviously, this burden will rise, and this population of aging population will not be the normal population. There will be so many aspects from medical, social, financial, and other support system which will be required to manage or to handle this aging population. So that's something very important, because the life expectancy in 1947, when we came out of the independence colonial era from the modern India, so it was 46 years, now it is 72 years. So the life expectancy has gone up, the aging population is going up, and the aging population will have some or the other diseases of aging, whether it is the neurological diseases or the other disease. So we have to gear up to face that consequence, and dementia is one aspect which is glaring at us. The huge money will be required to spend to manage these people living with the cognitive impairment or the dementia. It's not only the dementia, but strokes also. The number of strokes or the prevalence or the incidence of strokes has reduced or has come down in the Western countries, but in India it has doubled up in last 10 years. So the number of strokes and the mortality, again, both have gone up as compared to the Western country, which is seeing a reduction in the mortality as well as in the prevalence. So if we have the double the number of strokes in India in the coming years, it means the stroke survivors will be used. It's not only the case fatality, which is of course improving, but number of stroke survivors with disability will be a huge burden on the system. So that's again very, very important. The third disease which I wish to mention is epilepsy. So there are about 10 million people living with epilepsy in India, which is, I personally think it is underreported. So 10 million people living in India with a huge burden of treatment gap, 80% treatment gap for epilepsy. So that means even the basic drugs like valproate or levetiracetam or even phenytoin, which is rarely used now in Western countries, we have to make them available at every nick and corner of the country. So that treatment gap, of course, the government of India has come up with the national list of essential medicine, which include the anti-epileptic or anti-seizure medications now, but still there is a huge gap. The huge gap is not only causing a problem, but also it is a stigma also. So we are working towards destigmatization and improving the literacy about the epilepsy and the mental health as such. So that is where we again see a lot of gap, a lot of problem. In addition to the dementia and stroke and epilepsy, there are other diseases like Parkinson's disease, where again we have a million odd people living with Parkinson's disease, and this number is increasing. If you see 1% of the people living over the age of 65 years having Parkinson's disease, this is a huge absolute number. And then again, the treatment gap, not only the device-based treatment, but also the basic treatments of dopaminergic medication is not accessible, available, affordable. That is something which is very, very important. Coming to the out-of-pocket expenses, since we are at the brain economy, so there's a lot of out-of-pocket expenses incurred by the patients, and there's a study in Lancet which shows that every year 5.5 million people are going below the poverty line only because of the out-of-pocket expenses. So these are the challenges and gaps in our system. But having said that, there is a lot of effort from the policymakers now. I'm delighted to inform this august audience that Government of India has constituted the National Task Force on Brain Health, which I am the chairperson, and there are various ministries having stakeholding in this, whether it is Ministry of Health or Higher Education or Disability and Social Empowerment, Indian Council of Medical Research, Department of Science and Technology, Department of Biotechnology. So all of these are represented in this National Task Force, and we are looking at how to improve the brain health, not only in terms of making available the most advanced treatment, but also making available at the basic level, which is we call Ayushman Arogya Mandir. That's the primary healthcare system in India. And in the last 10 years, the Government of India has established 160,000 of these primary health centers in the country, which are the face or the first line of defense for any primary care, including the mental and neurological and substance use care. So we have developed packages, MNS packages and standard workflow for these primary health care doctors and the primary healthcare providers, so that they can be empowered to recognize the red flags and refer them accordingly to the higher centers, to tertiary care centers as well as the district health center. So that is something, strengthening of primary health care centers, and we are trying to incorporate brain health into that primary health system as well as at the district level. So brain health, focusing on particularly this aspect, we have a state of Karnataka where Professor Hachinsky is well known. We have one state which we started a pilot project in 2 districts where we established the brain health clinics in district hospitals, and that pilot project was very successful, and that now we have extended to whole of the state of southern region in the Karnataka, where all the 33 districts have now brain health clinics, and this is started only a few months ago. And that model we are trying to study and whether this can be replicated across India. The initial plan is to roll out in 2 states or 100 model districts. India has about 750 districts, and each district has a district hospital. So that district hospital can be mobilized to start brain health clinic. So that way, that will act as a bridge between the super specialty higher tertiary care centers as well as the primary health system. So that's where we have. And just for the information that we have a national mental health program, which is also district mental health program, and epilepsy is part of that. That is going on since 1980s. That's a successful program, but we are now revamping it, considering the brain health as a component, the mental health being part of that, and that will have some kind of a modification in that. Lastly, I just want to mention about research. The research, we have done a lot of work in terms of not only burden of disease, but also advanced neurological therapeutic research, which I'm part of the many of these, whether Professor Mayowa is heading those, leading those, and the other stakeholders from our Indian counterparts. We are all working together. And I think this initiative, Global Brain Health Partnership, will go a long way. And we are very happy and delighted to be part of it. And we look forward to have guidance and mentorship from people like you and Professor Andre and Professor Hachinsky, whether we can really help the poor patients in our country in terms of their improving their brain health. And then, of course, if these brains are better, the economic development takes place in that scenario. Thank you very much for giving me this opportunity.
Fantastic. I want to remind you, the panel, and also the audience, that we are learning from experts like you and Olabi and Hachinsky. We are just providing a platform and creating a community as a service. So but thank you for your kind words. I want to ask you a follow-up question on your talk. This national task force for brain health by the government of India, it really should be from what you're describing and who's present, it's a national interagency task force, right? There's so many parts of the government that's involved in it. Can you tell us a little bit about the relationship between this task force and IGAP? What was that link? And what was the genesis? How did it come about? It was like the president said, let's do it, and prime minister. So, and then do you have funding from the government to carry out your mandates?
Yes, thank you for that. So the whole idea of having a national task force came up from the WHO resolution on the eye gap and in its implementation on epilepsy and other neurological disorders by 2030, and India is a signatory to that. And in fact, I was the one who drafted a presentation from the Indian delegation to the WHO General Assembly, 75th General Assembly. So we are part of that, and being one of the largest, now the most populous country in the world, we have left behind China, and we are the most populous country, and we have a mandate to implement the eye gap, and that was the idea of having a task force on the at a level which is intersectoral actually. So we have the leaders in the terms of neurology, neurological associations, whether it is Indian Academy of Neurology or Neurosurgical Society of India or Indian Epilepsy Society. All these stakeholders are having the presentation, and that task force is mandated to implement the eye gap in the country by 2030. The beginning has been done. It's a slow process, but I believe that the whole process is to, the idea came from that only, and I think there's a general consensus that we should have a plan to task force to give us, the policy makers, an idea how to implement the WHO eye gap. Unfortunately, the WHO in its implementation plan does not figure India in that scenario, but we have spoken to the brain health unit in the WHO team, as well as the regional office in Delhi, as well as the country office in Delhi, and they are very happy that to support us. Just to answer your question on the funding, so this is fully funded by the Government of India. So the National Task Force is fully funded by the Government of India, 100% funding, and we are planning to have a conclave in early next year, where we will invite the international leaders, some of who are here only in this panel, and that will be fully funded by the policy think tank, which is called Niti Aayog, which is the Planning Commission, and Planning Commission is headed by the Honorable Prime Minister of India. So the task force works directly under the Planning Commission and under the direct control of the Prime Minister's office. So this is fully funded. There is no dearth of funding for the national task force, but for implementation at the district level and at the primary healthcare level, the states will have to chip in, because health is a state subject. So the federal government is only giving the directions and the broader policy, but the budget is totally the state government, because all 33 states have their own health budgets, and the health is a state subject. Of course, Planning Commission will roll out this the program on the brain health, which is already in the pilot stage at Karnataka, maybe in 100 districts, model districts, that will be fully funded by the Government of India.
Fantastic. I'm going to come to Professor Owolabi, and the question I have for you is, you just heard from Professor Damija that the Indian government has really a high level political buy-in and support for implementation. Have you seen on the continent something similar, or what is different in terms of implementing IGAP at the country level?
Yeah, thank you very much. Like I said, the way we wanted to approach it in Africa, was to go through the WHO. We had a document which we developed with the WHO, which is supposed to be launched. At the launching, ministries of health of about 5 countries are supposed to be invited. That is yet to happen. But at the country level, for instance, in Nigeria, I'm already engaging with the Ministry of Health in Nigeria about brain health, about stroke. And in fact, when we're going to Zambia now, government officials in Zambia are going to also be part of the program. A minister in Nigeria may even be one of the keynote speakers at the program. So we are engaging using what they know and what they see, things like stroke, and of course, risk factor for stroke like hypertension. So Ghana, Nigeria, Zambia, we are really engaging. And then Ethiopia, I think to some extent, are also being engaged on brain health. But as a continent or a subcontinent, we also want to use the auspices of the WHO to even do this more.
Great.
Then in Nigeria, a series of documents in Nigeria has been launched for NCDs to improve NCD control, including essential medicines, including legislations against tobacco, against unhealthy food. You know, that was just launched about 2-3 weeks ago, and also including task shifting, task sharing. So, and those are really very, very powerful tools that can be used for advocacy. Universal health coverage is working very well in some countries, like Botswana, like Ghana. For instance, hypertension is treated for free in Ghana once there's a prescription from the doctor, you know. And then we are also trying to work with primary health care centers. Thank you very much.
I have one two-finger for that, your response. What's the role of Africa CDC? You mentioned Afro, but the office.
Yeah. Okay. Yeah. So you see, African CDC, like many other organizations, they still have this myth that Africa is all about infectious diseases. So they're very, very aggressive when it comes to Ebola, to COVID-19, to TB, you know, to malaria. They are really very aggressive on those fronts, or even polio eradication. But when it comes to things like stroke, like dementia, I think they are just beginning to, you know, we are nudging them. We are trying to let them see that the burden of these conditions are even overtaking that of those infectious diseases.
Thanks for that.
Many of the global funding partners, these NCDs are not there. But like I said, people are beginning to realize just about less than a month ago, like I mentioned, the Minister of Health in Nigeria launched about 8 different policy documents on the control of NCDs. So I think they are beginning to realize this, and the African CDC, maybe over time also, will imbibe this.
Yeah.
Thank you.
Once again, that link between IGAP and NCDs. Professor Hachinsky, I will come to you, and I'm going to have a follow-up question for Alex, which is, in our respective professions, in your situation, you're a neurologist. To what extent has the organized neurology, right? The World Neurology, is it Foundation, World Neurology Organization, I think it is. But
Federation of Neurology, yes.
Yes. To what extent is there, you know, how important are they, and what are they doing? What aren't they doing?
Okay, well, first of all, when I became president in 2010, I asked what the mission was, and they told me education, advocacy, research, etc. And I said, how's that different from any other organization? Well, I don't know. I said, can you tell me what it is? So you can't tell me, how can you implement it? So we boiled it down to a single statement, and that was the mission of the World Federation of Neurology is to foster quality neurology and brain health worldwide. Now, the following year, there was the second time that the General Assembly of the United Nations was having a resolution on health and how to do with chronic diseases, pulmonary disease, cardiac disease, diabetes, and cancer, no brain. So very quickly, we organized the World Brain Alliance. And so we got the International Brain Research Organization, Alzheimer's International. I'm happy to say my friend Peter Black from Massachusetts, a mentor of, was part of it, the Neurosurgery Society. But most importantly, we had the World Psychiatry Association. And they did not insist in calling it the the Brain and Mental Alliance. So we founded the brain health on 3 premises. There is no health without brain health. It begins with the mothers and the child and their education, a very important one globally. And the third one, our brains are our future, in the sense that even then it was obvious that in a knowledge-based society, you need to have greater brain health and competence to function. So, and anyway, so it's a bit of a long story. We managed to get item 18 in the resolution, which says they recognize the importance of brain health and, the importance of neurological diseases, including Alzheimer's disease. Now, thereafter, I think they have been efforts, and IGAP is, I think, the consequence of some of that initiative that we started. But very specifically, when I was president, also we introduced a brain health day. No brain health, sorry, a brain day. And this year's is
Great day.
about brain health, actually, so I'm happy. Now, the other thing that's happening is that there's a lot of activity. I mean, if you look at the publications on brain health from 2010, it's not exponential, just like a spike, great interest. And then, however, in terms of plans, there's a European brain plan that was launched 2 years ago. And there's, of course, there have been national plans for a number of times. The first one was Norway. That was implemented in in 2018. And the first 5 years are going to end in December of this year. And they have a task force where they're going to set the priority for next year. So there is activity. There's also an American Academy of Neurology plan. However, I would say there's a common limitation, and that is it still is asking government, give us more money so we can do more, but better. And, you know, I mean, there are other priorities because the WHO has a very good plan, but depends on national governments. And many governments have more urgent plans. So in addition to having what I'm calling a tops-down approach, we have to grow the grassroots and connect them. And I think the problem is that a lot of the approaches don't take into account that, you know, if you have one neurologist per million in India, you're going to make a big impact at the personal level. It has to be at leadership level, training others. And we have to go beyond. We have to start working with pharmacists. We have to train internists and family physicians, put on the basics. And then lay people can do it. And of course, the big thing is to change the mindset. Brain health is your problem, or at least it's your, not problem, it's your opportunity. So I do think that there is a lot of activity, but it's still at the theoretical thing and prescriptive. I think we have to begin having a demonstration models, of which we're trying to have one. You know, action speaks 1,000 words. So I have a rather different approach, sort of bottoms up and at the very basic level. And, you know, let's work with whoever, most importantly, with the people affected, which, as my friend Marwa said, is everybody. Everybody has a brain. And if it were an expensive computer, irreplaceable for the lifetime, we treat it much better, or even a car that we treat our own brains.
Thank you, Professor Jasinski. Excellent. Alex, you want to speak on behalf of neurosurgery?
Yes, thank you. Thank you to everyone for starting what hopefully will be an ongoing conversation. So what I'm really most struck by is the importance of communication and dialogue across specialties. So sometimes we are not working as closely with our colleagues in neurology and psychiatry and rehabilitation medicine and all the parts that touch brain health. We need to collaborate across countries. We need to collaborate between people doing population science and people on the ground taking care of patients. And that's really my takeaway from listening to these fantastic talks, is that we need an opportunity to talk as much as possible, and therefore make our voices more amplified, because there will be more of them, and also to learn from one another what's working, and push on those things that seem to be getting some traction.
Thanks, Alex. So I will be asking each of the panelists, by the way, thank you for each and every one of you. I've learned so much today, just as Alex was saying. And it's inspired me to even, to say, we need to do this more often. I think when IGAP came about, the most important word was intersectoral, because it forces us to start talking to one another, and in of itself is amazing. You're seeing this now. But I want, as you think about your closing comments, think about what one thing that you want the audience to take home, and then what's one thing that we as a group can do as an action item. So, and I also put in the chat for the audience, any questions. This is the last time if there's any questions to ask. Oh, I don't know who just popped in. Hey, Sarvani. Great to see you. Oh, she's gone again. All right, then let's see. Alex, do you want to go first?
Sure. So I think as the neurosurgeon on the panel, one point that I'd like to leave folks with is that neurosurgery has often been felt to be too difficult to implement in lower resource settings, that it takes too long to train neurosurgeons to increase the numbers of practitioners, and that is not true, that there are really currently huge increases in the numbers of young physicians wanting to train in neurosurgery and being trained in neurosurgery thanks to some efforts from the WFNS, but also more broadly. And that this makes a big difference because, again, surgical brain diseases are common. They affect young people, and they have a lot of potential impact on that kind of societal brain health that we heard about today that is so important in order to really benefit from all of the technological advances that the world has, and the kind of knowledge economy.
Thank you, Alex. Perfect comment. So there's a question that just came in from an Ursula, and I'm just trying to figure out how we can either get her. Oh, there you are, Ursula. You can unmic yourself and ask your question directly. Go ahead. Is she able to speak? Oh, there you go. If you have a camera on, you're welcome to come on the screen. So I don't see a microphone next to her name. Let's see.
Maybe our audio is not connected. Did you connect your audio? Can you hear us?
She's unmuted, but I don't see. Oh,
Okay,
yes.
okay, now I think she's probably
Okay.
reconnected. Can you unmute
Yes,
now?
we hear
Speak?
you.
Can you hear me now? I'm from Munich, and I'm a doctor for infectious diseases, and I'm very thankful for your input, and also that the brain is so important, that, and not all is infectious like you mentioned. I have the question, which is the most important point for in a sense of ecological problems of the world which damage the brain? Is it the heat? Is it toxic? Is it the pollution? Is it disruptors? Or what is the biggest danger for the brain diseases?
Can we get one answer for Dr. Van Geerk?
Well, I'll make a stab at it. They're interconnected. I mean, you cannot divorce one or the other, and they would vary according to circumstance. Pollution in places like Calcutta, and not Calcutta, actually, the capital of India, etc., they're absolutely damaging. At one point in Mexico City, the children were getting all sorts of deposits of, say, lead and other things like this. So pollution is a very important problem, but it's also related, of course, to global warming. So in fact, we can bring on all the problems together under one big umbrella. I just gave you the first part of the definition we use. The one for people, we say it's when you're thinking, you're feeling, and you're connect with others is at best. But the addition is in a safe, healthy, and supportive environment. So that takes into account, first of all, the physical safety. You know, there are a number of wars going on, etc. That's very important in some parts more than the others. Then you have the second part, which is the environment, which we all know that's important everywhere to different degrees. And the third one is support, and that takes in the inequalities and the access to care, etc., etc. So we can integrate all the problems of the world and the promotion of brain health at the level of the individual and at the level of the environment in the three aspects: safety, healthy, and also supportive. And then the other thing is we also leave it all to policymakers. But, you know, we can make a difference in everyday life. For example, people should be aware the cost of, say, eating meat. I mean, by the way, I eat meat. I'm not advocating. I'm giving an example. How expensive that is in terms of what price you pay for the environment, the price you pay for transportation, the price you pay for pollution, et cetera, et cetera. So if we get as far as I'm advocating for the individual, we'll also ask them, do one thing that benefits you and benefits the environment, for example. And that's, for example, eating more carefully as to knowing the price, not only the literal price, but the social and environmental price of the problems that we are creating.
Thank you, Professor Hachinsky. Would you like to follow up with your closing comments?
Yes, well, it's along the same theme that you see most governments sponsor little attempts at preventing stroke, preventing dementia. They're fragmented, not integrated. If we give them integral brain health, they can bring all these efforts, mental health, et cetera, under one umbrella. And also, in terms of policy, put integral brain health in all policy, because it'll touch on all the things that we would just ask the question. And then again, if we change the mindset, but if you ask for one thing, my advocacy is to change the mindset. So, and to begin action. Action, I mean, we can talk a lot, but until you demonstrate something, we will not be successful. We'll continue to talk. There was somebody who said, when all is done, when all is said is done, more is said than done. So let's get going. Now, I have some specifics because, you can talk about, you can advocate, but what specific do I have in mind? Well, the first step is let us adopt a practical definition of brain health that everyone can understand, and let's have a measure that can be used as widely as possible. Secondly, simplify, focus, first of all. Focus on people initially in success, people are going to change. And I give an example where we're focused on. Simplify. And simplify what we simplify for London, Ontario, may have to modify it in Botswana or in India. So again, have that being changed. And then implant. Already, I think it has been said that there are organizations that are tasked with health will add the brain health part, and then they'll carry it with it, implant it. And last but not least is this, that it has been well established that if a number of people, there's nothing like succeed like success. So if people are feeling better and doing better things that have you, well, that becomes sort of what other people want to do. And there's good evidence for modeling that if you change the mindset of 10% of a population, change follows very quickly. And you may recall that there was an American anthropologist called Margaret Mead who said, never estimate the power of a small number of committed people to bring change in the world. And so let's be part of that 10% that begins changing the world to foster better brains for a better future.
Super inspirational. I love it. And I agree with you. There is no simple unifying definition of brain health today. This is and that's a source of confusion and inefficiencies within brain health space. So thank you for bringing that up. Okay, someone asked about whether there's a recording. There is a recording, and we'll make sure that we share the recording with everyone that registered for the webinar. And we're still trying to figure out whether we can place it someplace, probably at the PGSSC. We'll put the website on the chat, and then we'll put it into one of the archives. Professor Owolabi, and then we'll have the final word from Professor Damija.
Yeah, thank you very much. Let me quickly start by the question, addressing the question by Ursula. It's the predominant burden of neurological conditions may vary from place to place, may vary across the life course. But when you pull everything together, stroke is on top, followed by neonatal encephalopathy. That's using GBD data. So it's most of these are, non-communicable diseases. Of course, dementia is also very dominant. So that's as far as that is concerned. Now, what is the take home? And like Vladimir has mentioned, You know, what you are doing to prevent stroke is also preventing dementia, is also preventing cardiovascular diseases. And that has been illustrated by what Norway did by having a brain and heart policy, which of course reduced the burden drastically by over a third over a few decades. And I'm sure India and other countries are following suit to have that kind of game plan. So what is my take-home message? I will say, even though it's one, I will say two. The first thing is prioritization. Meaning that at the individual level, brain health should really inform our lifestyle, our habits, what we eat, how we take care of ourselves, because our brain is our priced possession, so to speak. Once the brain is gone, you know, what is left is a vegetable, no better than any other mammal or any other creature. What makes us different is our brain. So, and that means we must protect it across the entire life course. So I think that's a very powerful take-home message. And of course, we need to educate people. Everybody would like to protect their brain, but they may not know how best to do it, you know, and they may not be incentivized or supported to do it. And so social media, educational sector, we need to really get across to people. So the other one, which is also about prioritization, is at the government level, it should be a whole of government approach. It should inform every decision about all the SDGs. Because, I mean, when you're thinking about no poverty, no hunger, gender equity, educational sector, and so on and so forth, urban, all the things that you want to do, climate change, put brain health at the center of it, and it will really work. If you're thinking about growing your economy, put brain health at the center of it, you know? So, so that's is what I'm going to say about that. And generally speaking, I would then also talk about the brain quadrangle. Oftentimes, as doctors working in hospitals, we are often, you know, concerned and confronted with just the acute care pillar. Patients come to us and want to deal with that. You know, we forget about surveillance that, oh, for every single patient we see, there may be thousands in the communities or thousands at risk in the community. So, and that brings to bear the other pillars, which is surveillance pillar, you know, to be able to really count and know the risk factors that we want to target. The prevention pillar, which also includes promotion, including improving brain reserve, the concept of eumentia, which Vladimir has mentioned, and of course also supermentia. Then, of course, rehabilitation. So this brain quadrangle should guide our decisions and our actions, and they should work together as a continuum when we are trying to improve brain health across the globe. And I like the term brain health because it's shifting the way we're thinking about it. You know, we are always thinking in terms of diseases. Why can't we think in terms of health and health promotion? Thank you so very much.
Excellent. Thank you. Okay, Professor Damija.
So thank you once again. And I think my first takeaway is that we must make the politicians think about and talk about brain health. So political will, that is very, very important. And that's the least priority in many countries to invest in brain health. So make the politicians talk about it, think about it, and then convince them to plan something to bring the action. So that is where Professor Hachinsky said that talking and then action-oriented, the outcome-oriented, that is very important. At the end of the day, we have to have some action on the ground. And action can be not only in the treatment side. The neurosciences had done a lot in last 30 years. What we study neurology in 90s is different from neurology, which we teach now our students. So there's a lot of advancements in the therapeutics, in the diagnostic. But what we're lacking is the preventive neurology or the brain health, where we have not invested a lot. So we have been talking about disease. Now we have the time to talk about the health also. And a simple creating awareness amongst the masses, whether to cut down the sugar or to cut down the salt or to increase your fruits and vegetables or to increase your sleep and physical activity. So these things should be spread to in each person in the continent. So that way we can have a healthy brains and then can lead to the healthy economy. So that is number one takeaway, that we need to invest. Now is the time to invest in the brain health, that is the preventive aspect of the neurology, which we have not been able to do so till now. The other thing is equity. Equity is also very important. We need to work together to have that equity amongst all the, not only in the country like in India, but across the globe, so that each country has equal participation and equal accessibility. There is no huge gap between haves and have-nots. So that gap has to be reduced, and that equity has to be maintained and ensured that each person on this earth has the equal access to brain health and equal access to the treatment as well as rehabilitation. Number 3 is that the most of the governments are of the focusing on the in priorities on the their patterns of the disease, which neurology comes down. For example, the India has a very long-standing program on the NCD, so which focus on cancer or on diabetes or things like that, COPD or renal. But stroke is a very small component of that, and epilepsy does not figure in that. So obviously, we have to revamp and rethink and reinvent the wheel so that the brain health comes into the center stage, and we can convince the politicians and the bureaucrats and the policymakers to think about it and then deliver it. That is also very, very important.
Great. You know, the comment on the politics is super important. And I'll borrow someone's line. Everyone has a brain, including the politicians. So
Yes,
have a
don't
skin in the game.
it's a difficult job, by the way. I wouldn't want to be politicians. We need them,
Oh.
and I empathize with them.
Yes.
But if
But
I
yeah, I
may
agree.
ask the question,
Yes.
Dr. Khamija, my
Yes,
understanding
please.
is that there's a declaration that was originated at least led by Alfred Nyamshi from Cameroon.
Yes,
And,
I saw that.
Cameron.
Yeah.
the issue is going to be put forth at the General Assembly because the incoming president is actually a former prime minister of Cameroon. So, do you know the status of that document?
Not to best of my knowledge, but I'll ask the Harris and the other people who are here, so that the president of the 79th UN General Assembly is the president of the Cameroon, from where this declaration came from. So obviously there are very high chances of being put into the resolution, but as of now they have not mentioned it. But certainly I will, and we will take it forward. And if that comes, it gives a huge exposure and huge commitment for the member states to work to get it done.
Thank
There
you.
was a sign-on form which I signed on to. I don't know if it's still available to be signed on. And if there's a link, we'll be happy to share it with the attendees. So on that note, I want to remind everyone, this was recorded, and we have our team at the Harvard Program in Global Surgery. We will compile this into a sort of a proceedings, and then we will try to disseminate the contents, the key messages from this session today, into the literature somehow. I just want to say thank you to Alex, Professor Olabi, Professor Khamija, and Hachinsky for your wisdom and all your thoughtful comments. I've learned so much. I think Andrea's here. She's under the weather, and I saw Sharbani earlier too. The three of us will put our heads together, but with the information we have today, we have some direction. We have some ideas about how to assemble additional webinars in addition to the regional webinars, and we'll be in touch with each and every one of you. So thank you. I'm going to close with the line that I learned today, and I'm going to try to say it over and over again, which is brain health adds years to our life and adds life to our years. Did I get that right?
Yes.
Yes. Okay. Okay. Thank you, everybody. Thank you all for your
The
time.
opportunity has been wonderful.
Thank you.
Thank
For
you.
having us.
Thank
Have a
you.
good day.